So this is a study that I'm particularly invested and interested in as the national chair for the study. This is led through the cooperative groups, and it's available across the country because all of the cooperative groups are participating, ECOG, Alliance, SWOG. So in this clinical trial, we're building on a previous cooperative group clinical trial, S1500 or PAPMET, that was led by Dr. Monty Pal at the City of Hope. And that study established Cabozantinib as the best TKI, or the best standard of care, as the first-line treatment for patients with metastatic papillary kidney cancer. So building from that, we're trying to find better ways to control the disease and help patients live longer, healthier lives that happen to have metastatic papillary kidney cancer. Some previous studies have shown that immune therapy, specifically checkpoint inhibitors, also have significant activity in this disease. And there's some single-arm prospective studies, a series of them, looking at various TKI IO combination options. Len-Pem, led by Laurence Albaget, Memorial Sloan Kettering with Li Chung, led Cabozantinib and Nivolumab. Cabozantinib and Atezolizumab was done, at our institution and others as a phase 1 study. So there's a number of these TKI IO combinations, and they all show very robust, impressive progression-free survival data compared to historic controls. For instance, specifically compared against SWOG 1500. So we hypothesize that the combination is going to be more effective in papillary kidney cancer, similar as it is to clear cell kidney cancer. So in this clinical trial, we're randomizing patients to the current standard of care, which is Cabozantinib, versus the combination of Cabozantinib plus Atezolizumab. Certainly one of the challenges that we are asked about frequently is, given that we have a multiplicity of single-arm phase 2 studies now that all show impressive progression-free survival rates, why not just accept that as the current standard of care and move forward? Why do we need to do this randomized clinical trial? And the reason I would suggest that we still really need to do it is that, based on a large part of this argument is rooted in the data from clear cell kidney cancer, that the combination seems to be particularly effective for that disease. But that argument is also built into the idea that Cabozantinib, or any of these TKIs, is really synergistically activating the immune system to lead to a synergistic immunological effect. And I will say, based on the long-term data of all of these TKI IO studies in clear cell kidney cancer, we're not really, I would argue, we're not really seeing significant immunologic synergy. So there certainly is rationale that the sequential option of starting with the standard of care Cabozantinib and subsequently doing an immune checkpoint inhibitor later can offer less financial toxicity to patients, less financial toxicity to our system, and less treatment toxicity to help support a better quality of life. So there certainly is a rationale that a sequential option may be just as effective for patients and less toxic. So I think it's time for this rare cancer that we do a randomized study to really understand what's the optimal way to treat these patients.